D'abord, merci aux organisateurs de m'avoir.
Well, all my thanks to the organizers for inviting me. 10 years ago, this sort of meeting would have just had dermatologists, but things have changed since then. But you know that, and so do I. Well, I'm talking and trying to solve a problem at the same time. So dermatologists who work in cancer treatment centers. Finally, you work with a maximum number of molecules because you have patients who come from medical oncology, pneumology, dermatology, neurology, and so on and so forth. So these dermatologists, including myself, gradually we have had to include and actually digest all these new molecules. Initially, they used to be not the kind of specialty that we were supposed to handle, and to handle all these different signal pathways, and there's a great mixture and combination. So quite naturally, I'm not going to talk to you about the skin toxicities of new treatments, but just a few ideas to help you in your patient management or toxicity management, and then just some general ideas. Now, let me give you some initial conclusion immediately. We all believe that dermatologists require a synergy, especially this transatlantic synergy, especially with Mario, because as you all know, molecules are very quickly registered today, and the dermatological assessment is often in the pivotal stage, and it is done through a macroscopic assessment which finishes with a certain amount of rash. Rash in itself doesn't have any dermatological substrata, and as a result, after the approvals given to the molecules, that we discover or we identify some of these adverse events. And let me tell you about what was done with the memorial, when we worked with them. Now this product, which has just been approved, was registered, actually, Cadzilla, without noticing that it had this toxicity. It's not just an adverse event, but it's unexpected. 90% who got Cadzilla actually develop adverse events. And so for the time being, you don't find it in the Vidal or in the molecule, but it's extremely frequent. And why is that? Because we were, let's say, lucky enough to have observed these patients who developed, under treatment of several weeks and several months, a kind of telangiectasia, which is very widespread on the skin and which is not really noticed either by the patients themselves, by oncologists, who are more sensitive, in fact, to this sort of dermatology. And this is a typical example of molecules which are approved without, dermatological toxicity, and which are often individualized. Now, if we continue with Cadzilla. Now, Cadzilla, as you know, is a molecule for second line, and it's meant to be an adjuvant treatment for breast cancer. Now, 25 to 30% patients have bleeding, minor bleeding, which was normally attached to thrombopenia initially. But if you take a closer look at the studies, this has sometimes severe hemorrhage is not related at all to thrombopenia. And when they have more severe hemorrhage or bleeding, are not normally thrombopenic. So we believe, because we opened our patients' mouths and examined it, that they developed a telangiectasia in the mouth and in the digestive tube as well. And quite often, I'm not confirming anything, it's an interesting path to study. All this hemorrhage that we see in patients on the hands are not related to thrombopenia, but to a vascular malformation caused by the treatment. This is a good example of transatlantic cooperation, which I really wish to share with you. I won't get back to the signal pathways. It's just that today, in our daily lives, we are confronted in consultation with a very high number of patients who have toxicities related to targeted therapy. Now, there are some traps here, but I'll come back to them. It's not just targeted therapy that I'm showing you here. Now, of course, we can talk about everything, all the signal pathways, molecules, family of molecules, but that would be too exhaustive for this late stage in the evening. So I suggest that we look at these signal pathways and their relationship to the skin. In just a few years, dermatology has gone from a microscopic aspect to a molecular aspect, and it's really fascinating as a dermatologist to see this change. So now we'll be talking about the EGFR receptor, the angiogenic receptors and so on, but that's just an example of the BRAF and so on. So when you inhibit these receptors in the tumor, most of them are also expressed in the skin and expressed physiologically, not just in the skin, but they also play a fundamental role in the skin homeostasis. I'm cutting short, of course, my explanation, but generally, all treatment that will inhibit certain signal pathways in these receptors will do it on the skin as well and lead to a very special kind of toxicity. Now, let's talking of RAFs or BRAFs. So we were getting used first to the pan-RAFs, which now we've been handling for several years, and then the BRAFs. But it's the same spectrum of dermatological toxicity. Generally, it's considered that the keratinocytes and certain melanocytes, which are not BRAF mutation bearers, instead of being inhibited, have a paradoxical activity, and this gives rise to a whole lot of adverse events of keratitinite events. And the best individualized is in those patients who develop in just a few days and just a few weeks the squamous cell carcinoma. That's about 20 to 30% of patients. So this sort of proliferation is due to these RAF or BRAF inhibitors, which plays a very important physiological role. So when you look at them more closely, you'll find a whole spectrum of hyperkeratosis because of these induced hyperkeratotic lesions. You've got some papillomas. They're not easy to differentiate from a real epidermoidal carcinoma. So you often have these keratosis pilaris-like lesions, which are quite difficult for the patient. Similarly for melanocytes. Now this is more interesting. Now, of course, the BRAF inhibitors were initially developed in metastatic melanomas too. But all melanocytes do not have this mutation, and those which do not have the BRAF mutation, they will proliferate. So that means in 10% of patients, generally, they develop a new melanoma. They're treated for a metastatic melanoma, but they develop melanomas, not very thick, because we are really monitoring them. But today in France, metastatic melanoma is handled by hospital dermatologists, which is not the case in other countries like the USA. And it's certainly not the case when they use BRAF inhibitors in the colon or elsewhere. And quite probably, melanoma will appear in these patients with a later diagnosis, who have perhaps a better prognostic outcome, as opposed to those who have a metastatic melanoma. Now, the EGFR inhibitors. Receptors, you've got the same dichotomy. On the left, you've got the tumor cell, which expresses this receptor. And here you've got the keratinocyte, which expresses the same EGFR receptor. Now, in green, you've got the same anticlonal. It binds, to this system, and on the right it will distribute the proliferation in the epidermis. It plays two roles: proliferation of the epidermis and its reaching maturity. If you inhibit it, you will give rise to a coronary layer, which would be totally inoperable, and it'll have all the symptoms that you know of through EGFR inhibitors. Similarly, if you inhibit a little downstream these signal pathways, that is with the anti-MEX, you will have the same dermatological toxicity. Now, what was summed up by Mario as PRI, that is paronychia, problem with hair growth and itching, you will have virtually the same toxicities, more or less, with the anti-EGFR, the anti-MEX, and most of the pan-HERs. For instance, as you all know, the HER2, you have just a few keloid reactions, but not a toxicity which is specific. And why is that? Because the HER2 receptor is not expressed in the skin, virtually not. So now acne-like rashes, the HER inhibitors, once again, it's an expected result, and it's essentially in the sebaceous areas, on the face, and on the scalp. And what I would suggest is, and this is going to be published, that when you have forms which are slightly chronic and resistant and which are located essentially on the arms, because this could happen with peritomy, but warn them against the MRSA. Now, I talked to you about the cornean layer, which becomes inefficient, so that leads to skin dryness. Like over here, this is what you call the cracking eczema on the legs, fissures and psoriasis. So you have fissures, digital fissures, which are very painful for the patients, and even on the ankles and heels. And now the periungual toxicities, you can see it's completely red. It's fairly early here. The problem is that it takes very difficult forms to treat, which is granulomas, which you see just on the bed of the nail, because once again the skin has stopped playing its normal role, so it penetrates the skin and leads to a chronic inflammatory reaction. Now, just to focus, because this is a subject I really like, what I would recommend is that you remember the nail toxicities through targeted therapy gives rise to nail toxicity. Chemotherapy is on the tablet itself, on the bed of the nail. This is just in short. If you take a close look at your patients, virtually for all the cytotoxic problems, most of your patients have nail changes. Sometimes it's spectacular, as you know. There's, due to taxane, you get all sorts of things. There are all sorts of modifications that you normally don't see, not for the patient, and which might give rise to some problems. Now, here we are. These are called Boon Lines, and that just means that at each chemotherapy cycle, there is a breaking up of the matrix cells. So your patient has had 6 cycles of chemotherapy. You can see them. And if it's a stronger process, then you see that there is a proximal lifting of the nail due to taxane. So this is called neoleukomatosis, and which is related to the first early sign. And now, this is a frequent form. I don't know if your patients talk about it to you, or maybe you have more specialized consultations. Sometimes these brittle nails are the reason for consultation. So this is a nonicus kivi, which is a sign of the brittleness and fragility of the nail plate. I did tell you that chemotherapy is long, and this therapy that you find is around nails, the toxicity is around the nails, but there are certain variants too. You've got the anti-angiogenetic inhibitors, so you have some ordinary the typical signs, which are a sign of impregnation, which is filiform, and in certain patients, you get it in melanoma, but it's not very normal. Let's talk about c-KIT. Since the early 2000s, we know that those who are getting pumatinib, they get depigmentation, particularly if they have a higher phototype. And this is somebody at the Gustave Roussy Hospital treated by Caroline. Sometimes they have hyperpigmentation. Now, they take on another dimension when you're getting sunitinib and pazopanib. You see that there's hair depigmentation. So when you see them in the waiting room, you know that they're taking their molecules, their treatment, which might sometimes have this sort of impact. It's not serious, but it's a functional impact, which is not negligible. Now, I've met this person just recently, the person under pazopanib. How old is he? He's 16 years old, right? So when he goes to high school, it's not easy. For him, it was a genuine problem, much more than the fatigue related to the treatment. It was this depigmentation all of a sudden, and because of the use of pazopanib, it was a problem for him to handle. There's another problem with these targeted therapies. I think most of you have seen it, and it's this syndromes, MAPI syndromes. They're very special. These are bilateral syndromes, the hand-foot syndrome, and they're often at the point of friction, pressure, and on your hands, it's also the grip that suffers. So, so that means you'll have to stop using the BlackBerry. Very often you develop this system, on your fingertips if you're using a BlackBerry all the time, or if you play golf very often. So you have to go and see the podologist to improve the comfort of your walking. At the same time, you've got this other hand-foot skin reaction. This is the reaction to chemotherapy. It's not the same clinical presentation. There is an erythema, which is very disseminated, and this is hyperkeratosis. There were several targeted therapies, and as I said, it's really on the feet. I'm talking about this hand-foot syndrome. It's related to several things, but it's essentially in dermatology. It is, of course, the intensity of the symptom is one point, and it's measured in clinical trials, but what's important is the duration of these symptoms. In dermatology, that's a very important issue. The impact on quality of life of a patient with metastatic breast cancer. It's followed over several months. It'll be cisplatin, which will be grade 2, moderate. With the use of amphetamine, will have this sort of hand-foot syndrome. And then you might have someone else with a very strong syndrome, but which will only last for a short period. I think the duration of the symptom in dermatology is extremely important to measure. Let's get back to our targeted therapies. Now, why is it that ipilimumab doesn't really give it, Why don't you have this hand-foot reaction or syndrome? Because if you compare these molecules, the incidence and prevalence of this hand-foot syndrome, you must have the PDGFR and EGFR and BRAF on a large scale. Because if not, you won't have this hand-foot syndrome. You can virtually predict the development of your molecules, those which will have this sort of syndrome. Now, if the pharmaceutical companies were to look at that, then you wouldn't have these reactions. Now, I'm not talking about the ICIs because this was done really well by the earlier speaker. In dermatology, it isn't such a problem compared to other organs. And if you look at the examples of the papilla, macula, and so on, there's also lymphocytes, and there's also ipilimumab. There's a metastatic melanoma. Now, also examine their mouth, which is not something we do often. And you will find that toxicity in the mouth is very different from that compared with chemotherapy. These lesions are aphthous compared to what you see in chemotherapy, with the keratinized color of the skin. It's not the same clinical appearance, but the functional approach would be virtually the same. Another interesting point, we dermatologists have realized, and practically with the first prescription of mariosimab, developed these geographical tongues.
And, well, 99% will be put on antifacism. But the fact of inhibiting VEGFR, VEGF or its receptor, actually opens up perspectives about the geographical tongue that only affects 3% of the population. And by the same token, get your patients to open their mouths. because patients on BRAF inhibitors develop hyperkeratotic oral lesions. It's inside the mouth, so it can go unheeded, and it can then only be caught when it's quite late. And to wrap up, back to the pictures on the beginning. So is that targeted therapies or chemo? That's a keratoacanthome. So it's targeted inhibition of the BRAF. That's depigmentation of c-KIT. What is this? It's pretty typical. Bleomycin pigmentation. Well, to the left usually does not correspond to targeted therapy. In the middle center picture, that's targeted therapy. Here, chemo, yes. And here, bottom right-hand side, because we've talked a lot about targeted therapies, but when you look at outpatients in oncology units or oncology centers, toxicity of targeted therapies is pretty well known, but the old chemotherapies, the toxicity of old chemotherapy treatments is not clear. Therapists are not very much at ease with it. So I think it's even more important to go back to chemotherapy because you have more patients on traditional chemotherapy. So that's relatively new, but it's something you need to factor in because it will help in your daily practice. Toxic means that it's not immunoallergic. And if you have patients on taxane, well, you have certain types of lesions that are sometimes on the back or on the at the back of the knees. So with cytarabine, you have some more rarer syndromes or the hand-foot syndrome. So if you factor this in, I can promise you that it will help you in your management of your patients. That's what the hand-foot syndrome looks like. The toxic erythema of chemotherapy typically looks like this. And here we call it the magpie nest because it's clearly at the junction of two parts of the body. That is really part and parcel of your daily practice. Well, the picture is a bit graphic, but that is a classic toxic erythema induced by chemotherapy. So it's bilateral, the level of the waistline, and you see the lesions. It doesn't mean that it's not serious. You need to monitor those patients. And lastly, yes, there are toxic erythemas, but you need to still have good reflexes. There can be Steven Johnson or other serious affections. It's quite rare, but your patients are on antibiotics, anticonvulsivants, antalgics, and so there can be actually cutaneous reactions that don't have to do with targeted therapies. And we've seen some drugs being reintroduced despite those reactions that are fairly severe, but always wonder, you have to ask yourself the question, can it be of immunoallergic origin? If an erythema is very wide in terms of surface area, if it's very intense, if you have a facial edema, if there's skin pain, Skin pain should always alert you. If there's fever, if there's peripheral lymph nodes, if there's transaminitis, all these are criteria that should alert you. I thank you for your attention. I'll come back to the emergence of supportive oncodermatology. I am fully convinced of the point of these of this supportive oncodermatology, and I hope I have convinced you.